Good afternoon, everybody, and welcome to another episode of the award-winning Recovery Podcast brought to you by the McShin Foundation. Get in the herd. Here we are in Richmond, Virginia, broadcasting all across the country, and in some cases, we're even getting picked up a little bit across the world. So today we have I'm excited because I already see some people watching, some numbers up here. I'm really excited to have some real advocates doing some amazing work from Rhode Island, the Ocean State. With us today, we have Haley McKee, Michelle McKenzie, and Sarah Edwards coming from Rhode Island to talk about three bills, this hat trick of legislation that has just been passed. And what we've just learned is all three bills have now been signed by the governor and will go into law. So, Haley, would you walk us through the three bills that just passed? What happened?
Sure. So, there's a lot that happened in the last few years to have these bills come into fruition and become law. So the three bills that you're referring to as the hat trick are the reclassification and defelonization of simple drug possession. That is for people who are charged in possession with 10 grams or less. That was led by a lot of different community advocates, as well as the Attorney General's office here in Rhode Island. There was also the decriminalization of buprenorphine. We are the second state, right behind Vermont, who passed that law as well last month to decriminalize that medically assisted recovery medication. And the one that's making all the waves is the Harm Reduction Center and Pilot Program that just passed in Rhode Island law and is the first in the nation where a person will be able to bring pre-obtained illicit substances into a medical facility and use under medical guidance. So we're really, really excited about all these new laws and all the opportunity to save lives in our little tiny but mighty state.
Tiny but mighty. So, for the three of you, I love that these three bills. One of them is something we're really trying to bring forward here in Virginia, the reclassification bill. And I know that some of our listeners have been hearing me drone on and on and on about it, but it's very important to me. It frees up an individual, so it gives them an opportunity to actually who wants to get help without fear of suffering legal consequences. I was confused about the buprenorphine bill personally, and I know when we spoke on the phone, I was sort of confused about that. So, personally, I didn't know what this was about. So when you explained it to me, I thought, wow, that's something we need to consider here in Virginia as well. And it's something that I learned. A colleague of mine, an associate of mine, has suffered from problems arising from having this on him here in Virginia. So explain to us, if you would please, because I'm stumbling right here. Could you explain what the bill does, why it was necessary, and why it continues, why it will be a good thing for the state?
Did you want me to take this one, Nathan?
Whoever wants to take the lead on it, sure.
I'm happy to speak to that. The importance of decriminalizing buprenorphine is that what we found in research is that most people who use buprenorphine that's not prescribed to them use it to treat withdrawal and to keep from being sick. And so people really use it medically and use it to take care of themselves. And there's a lot of reasons that people aren't able to access, their own prescribed buprenorphine. It could be that if they don't have insurance, if they don't have access to a clinician. I mean, what we know is that in the United States, there's many areas of the country that don't have a prescriber. And even if there is a prescriber, there may be all kinds of barriers to accessing a prescriber. So there's multiple reasons that people don't have their own doctor who prescribes buprenorphine. And so making it available, so having it, decriminalizing it means that might not be the ideal way to get it, but it recognizes the fact that people are really looking for buprenorphine in whatever way they can get it, including from their friends, family, and neighbors, even if it's not from a doctor. And
so what I thought when I heard this legislation, I thought, what? doctors can't prescribe this, and of course I was confused. Which is kind of silly. I should have really thought this through. So now you're telling me an individual who just has it on their person but doesn't actually have the physical prescription available is not going to get charged with a crime for
Right.
yeah. And so why is this important in Rhode Island? I mean, you've explained, of course, medicating themselves, but why the need for this bill? How many people have been affected by this?
I'd be happy to just give a small anecdote about why it's so important. So I'm a person in long-term recovery. My drug of choice was opioids, and granted, this was many years now in the past, but I was someone who bought Suboxone off of the street, right? I actually bought Suboxone from my dealer. So anytime I wanted to quit, and I really didn't have the ability to go to somebody and ask to go to treatment out of fear of getting in trouble or, just being vulnerable. I just wasn't always ready to ask for that next step of help for whatever reason, it doesn't matter. But I bought Suboxone illicitly. I was not prescribed it, but I got it when I was really actually trying to stop using. And in a few instances, it was really helpful. And luckily, I was never met with punitive measures for having that Suboxone on my person illegally. But it's, from my experience also as an outreach worker, there's so many individuals that we serve that do the same things that I did, buy Suboxone off the streets when they're trying to kick it. Because for whatever reason, maybe they just don't want to go to treatment, or maybe they have trauma from going to primary care physicians. Maybe they don't feel comfortable. Either way, it's a medication that helps, and it shouldn't be criminalized.
And I think I'd just like to add to that buprenorphine is a safer, much safer medication than using fentanyl. I mean, we know that fentanyl is really poisoning our drug supply. And so, and there's not one kind of fentanyl. There's hundreds, more than hundreds of kinds of different fentanyl because it's changing all the time. And so people accessing buprenorphine rather than using fentanyl is a much safer alternative just because of the way it works in the system. And so it's really to be applauded that people would seek buprenorphine.
Absolutely.
And I think it's also of note to mention these are all really valid points. And also additionally, so when patients leave with the pharmacies with their boxes of buprenorphine, they're in single dose sublingual strips often with no identifying information on each one of them. So anecdotally, I've been meeting a lot of people in Rhode Island who are actually medical patients. Not that it matters, but these are people with valid medical prescriptions who are also being arrested for felony possession for their own medication. And that's been a large problem in our communities as well.
Well, and so to that point, so now we're going to have that legalized, right? And so now people will be able to just, transaction on the street. What were the arguments for and against? And as a bill, how was it received? Was it a bipartisan bill? What should we expect if we're putting something like that together here in Virginia as far as pushback and answers to that pushback?
Okay, well, I can say that here we do all nonpartisan drug policy. We approach this from a lens that this is not a political issue. And in our climate, it's pretty fractured, where our two main camps in our General Assembly are either progressive Democrats or conservative Democrats. There's like a small number of Republicans somewhere in the mix there who generally get on board with our policy as well. But we came into this and said, we're not going to pick sides. We're not going to frame this as anything because that's not what the issue is. And that's where I found that we've had the most success in buy-in and had universal support, because we have not politicized this issue in any way, shape, or form.
That's awesome. Robert Legg asks a question here. Sorry, Justin. Robert Legg asks a question. He says, in Virginia, only pregnant women can be prescribed buprenorphine. Everyone else gets Suboxone. Do you have Suboxone also? Is bup a pill or sublingual like Suboxone?
So, in Rhode Island, it is more common. Suboxone is more commonly prescribed as well. Buprenorphine is just the is just the generic name for it's co-formulated with naloxone, which is Suboxone. So it's the same here, that it is more commonly prescribed. Although buprenorphine is available, it's just less available. And I'll just say that part of the reason that that's the case is that really we've had, unfortunately, and one of the things that I'm very excited about with this legislation is that these three pieces of legislation are really important continuation of changing the approach that has been in the United States for the last 70 years, which is approaching use really as a criminal problem. And so many of our energies have gone into treating it as a criminal problem rather than recognizing that use, if people develop harms associated with use, then that's what you need to address, not the use itself. And so the whole co-formulation of buprenorphine and naloxone together was an attempt to really to restrict access to the medication buprenorphine. And there's been lots, as we know, that medications for opioid use disorder have had a lot of restrictions to them, both at the national level and the state level. If you look at how methadone is used and all the restrictions associated with methadone use. And likewise, there's fewer restrictions with Suboxone or buprenorphine, but there's that same kind of control. And that's the reason, for instance, there's been such tight controls on who can prescribe it and how much they can prescribe. And that is changing now in recognition of the importance of increasing access to medications for opioid use disorder.
Awesome. I'm so grateful to have this knowledge and to now have a new issue. One of the things that our show does, and what you probably don't know, is that we take the show and we give it to PayTel, who distributes. PayTel is an organization or a company that provides tablets and stuff, content for people who are experiencing incarceration. So we give it to them free, and this goes out to 48 different, I think we're at 48 jails and prisons across the country now. So we will get upwards of almost a 300,000 per quarter a year. So we're looking at about 1 million people, million views a year. The reason I bring that up, because it's awesome. Yeah, we get the numbers. It's great. But I think that when we identify issues like this and we start, as advocates, when we're working on these issues, for me, I discovered, a lot of the gaps in what was going on around the country. What was going on here in Virginia while I was incarcerated. While I was incarcerated for a possession charge, I'm a felon because of my substance use disorder. And so as a result of that, being able to see that. So I love that when we can bring these ideas that hopefully we're empowering or at least emboldening the next individual who might be hearing this in a jail cell to come out and say, you know what, that's not right. We can fix that. And here's a template. So Sarah, you talk about being a person in recovery. I want to pivot to what I think is my favorite part of the three things that you've got here now, the reclassification bill. And I think for any substantial access to recovery support, this is Nathan's humble opinion over here, for substantial change and increased access to recovery support services must include reclassification at a minimum. And so what is the next step for you all there in Rhode Island, as far as reclassification, defelonizing sample possession? What does that do now?
Well, hopefully it helps decrease the barriers that are currently in place for folks who are using drugs or have substance use disorder. As Michelle was saying before, how we criminalize substance use disorder and drug use in the state has never really gotten us very far. It's never targeted the actual issue at hand. It only has dug us even deeper and further and has exacerbated any inequities that we already see on a regular basis. Like you said, I'm hoping that this could eventually turn into legalization at some point of all substances. That's just my perspective. I think that if we could ever get there in the future, that'd be great, but this is a great starting point to stop criminalizing substance use. Because like you said, you have a felony, right? And I'm lucky that I have a clean record. I got into recovery at a very young age. So by the time I turned 18, I was already in recovery and my past didn't follow me. And I'm very lucky, and I recognize that privilege that I have, because all of my peers in recovery don't have that as much, and their felony backgrounds follow them wherever they go. Doesn't matter how well they're doing now in life, doesn't matter how many court fines they paid off, it will follow you literally everywhere you go. When you apply for housing, when you try to get a new job. So it's like every time you try to enhance the quality of your life, you're stopped. There's a brick wall. And then you have to explain to someone why you're a good person and how you've changed. So you have to have qualifications as to why you're a good person. And this just doesn't happen in other areas, in professional development or trying to find somewhere to live, which is a basic human right. There should be no barrier to that. So I'm hoping that this will take us in the direction where people no longer have to worry about if they can get housing, if they can get a job, if they can get a loan, so that they could start actually enhancing the quality of their life and not be followed around with a felony forever.
Sure. If I had diabetes and I was looking for a job, I wouldn't have to explain why I'm a good person, and I wouldn't have to define what diabetes means to me. I mean, I think that in the space, and what I love is the pivot that we've taken over the last several years to I'm a person in recovery, or I'm a person in long term, or I'm a person in sustained recovery, because we have the opportunity to define what recovery means. But in no other health issue do I have to do that to get a job or to get a new house,
Right.
or rent a car even. So
Right.
looking at some of the comments here, Carol Cruz, who's up in Connecticut, by the way, she's amazing. I don't know if you all know her.
Hi, Carol.
Hey, Carol. Sadly, Black and brown folks have a far less chance of being prescribed Suboxone versus methadone or nothing at all. I didn't know that. So
It's very true.
Yeah, that's right.
Mhm. It's very true.
Well, and I think that comes along the spectrum. I think that BIPOC individuals are restricted or have a disproportionate access to recovery support services, while having a disproportionate ratio of individuals in a substance use disorder, with a substance use disorder. Carol says, "Hey." Robert says, "Do you this is a I know this is a thing of Robert's, and I love this too. So, do you have drug courts in Rhode Island, and how will reclassification affect drug courts, as the prosecution won't have the threat of a felony record to coerce people to enter drug court?" That's a very pertinent.
That's a great question. So there was something that stuck out in this now law, that's defelonization, that kind of struck people as odd, and that was a 2-year misdemeanor that they added on deliberately into this bill. There's only one precedent in the state of Rhode Island for such a thing as a 2-year misdemeanor, which was a veterinarian bill, which had something to do with horses or something, but it was found, and the reason being is that drug court is typically can last up to 18 months. So they realized, and there were some political issues there, where the magistrate from the drug court was good friends with the House Speaker at the time, who's no longer the House Speaker, and the drug court magistrate was concerned that we were going to essentially shut down their drug court should this kind of legislation pass. What we say to that, right, which didn't happen. They put on a huge dog and pony show and invited everybody to drug court graduation, which was 13 people one year, which, hey, it's 13 people, but out of 1,100 people arrested for simple drug possession in one small state, 13 people isn't really quite cutting it. As my PAC is vehemently opposed to drug court and diversion court. We're more of the mindset of full bodily autonomy, decriminalization. However, we realize to implement change in small installments and hopefully get to that destination, we have to work with the existing system. So what drug court looks like in Rhode Island and what it looks like in other parts of the nation are completely different things. So in other parts of the United States, drug court is often utilized for things that could even be violent crimes in conjunction with symptoms of somebody who might be living with substance use disorder, where as in Rhode Island, it has been deemed what the prosecutors call white girls drug court. So they'll get a pass and an opportunity to be able to expunge their records. We see this as an opportunity that can still exist in the space, seeing that the 10 to 28 gram threshold will still be a felonious charge. And we're hoping that the people who are put into that silo, I guess, I'd rather that they're just decriminalized, but the reality is that that's not always going to be, that's not going to be the case for the time being, that group of people, which will be 40% statistically of the active use population in Rhode Island, that comes in above that weight threshold, hopefully will be one of the dozen, the baker's dozen who gets into drug court, right? Yeah.
And Carol says we like to change the name to recovery courts, which they're working on those changes in Connecticut. And Carol, I'll speak to that. I like the idea of changing the name to recovery court, and let's change what that means, because here in Virginia, the barriers to access to drug court here in Virginia mean I don't know if it's the same way in Rhode Island, but a felony possession charge means you lose your driver's license. So right off the bat, you're reliant upon other people to get you somewhere. Often these drug courts are placed somewhere inaccessible, so there's no public transportation. You can be called at any minute to go take a urine screen, which means your job is at stake. So these are really, I get recovery court, yes, but also let's make it a true recovery court that speaks to what the individual needs, not just what the state thinks is a punishment or a non-punishment punishment. So,
Right.
thoughts on
Yeah.
Yeah.
I think I totally agree, Nathan. While I think that, drug court has done some good for some people, maybe it saved their life, maybe it got them on the right track, which is fantastic. I don't want to knock that. I think that's great if it worked for you. However, it's almost a setup for failure, because if you, let's say, don't pass that drug screening, you could face repercussion for that. And reoccurrences are normal. They happen.
That's right.
It can be expected. I know when I was first starting my recovery journey, it was not this linear process where I hit all the check boxes and I started doing fantastic and I was following the law to a T. There was a lot of undoing and a lot of unlearning and relearning, and getting acclimated to society again. And there was times where I had reoccurrences, and drug court doesn't honor that. They don't honor the human side of it. It's like, you messed up, so now you are in trouble. Now you are going to be punished because you did not follow this set of extremely strict and almost inhumane regulations placed upon you in order to do well. It's just a setup for failure, and it's not fair. It's like, where else are you expected to, like you said, at any moment have to do a urine analysis? So it's just, I think it's more counterproductive than beneficial, but like Haley said, kind of one thing at a time, trying to get where we can, and continuing these efforts to get us to a place where we no longer have to prove ourselves as individuals, why we're worthy of redemption, right?
Right.
Yeah. I just really want to back that up. I think that the way that drug courts are only accessible by some people, not all people. You have to fit just the right category in order to access it. It reflects really the way in which drug laws are so arbitrarily enforced in our country. Because when you think about it, there's no evidence to suggest that different racial groups use significantly more or significantly less. And yet, who gets incarcerated in our country? We know that it's BIPOC folks. It's people who have less access to resources, less access to treatment. And it really just is, it's all of this explains why we feel like decriminalization is so critically important, because the way the laws have been imposed throughout the decades has been really unjust, and it's been a means of controlling people versus really trying to address the problems that are associated with use. It's not that there aren't problems or that there's never problems associated with use. Of course there may be, but we have a lot of tools, public health tools, tools from our own recovery capital, right? What do we rely on to keep us well? There's a lot of tools that are not criminal justice tools. What we found is that that's killing people, right? In Rhode Island, one of the reasons I think that this legislation passed is that we lost more people in 2020 than any year before to overdose. 384 people to overdose. And so the way we've been doing it ain't working, and we have to do things differently.
Exactly.
So is that so speaking on the reclassification, the impetus to do this, I mean, obviously it needs to be done. I'm all in here, but what was the driving factor? You're saying the increase in overdoses was a driving factor in making this legislation happen. Is that what I'm hearing? Because we had a 40% increase here in Virginia, so we were at 2,300 last year, which is insane, of course.
I think that.
Oh, go ahead, Sarah.
This legislation, this bill was even before the increase in overdoses, Super PAC specifically, and the AG's office have been working on this bill pre-COVID, pre-spike, although overdose numbers were going up before COVID in January. But I think regardless of where we're at numbers-wise, this should have always been the plan. But I think because of overdoses being as high as they are right now, we really had, legislators listen to us and realize how important this is right now. If overdoses weren't as high as they were this past year, would it have been passed? I don't know. But I think that regardless of whatever the numbers are, this should be common practice at this point. Haley, I don't know if you want to add anything to that.
Yeah, I think the main driving factor of all of this legislation passing, so I lobby over at the State House full time, and just from having conversations with our lawmakers, they're all personally impacted. There was a lawmaker who tragically lost his daughter to overdose death last year. The House sponsor on the harm reduction center bill has lost 2 close cousins to overdose. We have a committee chair who's in personal recovery. A number of other lawmakers who have disclosed that they're in personal recovery. They reach out and ask for help for their children. They have cousins who are living with substance use disorder. And I think that was the main driving factor, is that they've all personally experienced this because our communities have been so hard hit, which makes them empathetic and driven to look for change in an evidence-based way. That's my takeaway.
And so what do you say to somebody, and I love this because it happens all the time, right? I'll hear a sheriff say this: we can't arrest our way out of addiction, and then turn around and say, what if you don't arrest them, how will they find recovery, or how will they get better, or whatever, or treatment, I guess sometimes is what I hear. So what do you say to that? Because it's like, well, wait a second.
Well, our sheriffs say that you have to arrest your way out of addiction. We have a horrible police chiefs association in Rhode Island. Our law enforcement presence. What's that?
I said, tell me what you really think, Haley.
I'm not going to sugarcoat it. It's just one of those things where they were our main and probably only opposition these past few years. Otherwise, these policies would have come into effect and become law a lot sooner. They do not see eye to eye. We have a really formidable police chiefs association, and they've been a Death Star. Fortunately, we came out ahead this year, but yeah, they don't see the flip side and change. Yeah. They want to have control, and yeah.
In fact, wrote a letter of opposition directly into what we against these bills. So that's what we're working with.
Wow.
And I think that with regard to whether or not, what we know is that the number one cause of overdose when people leave incarceration is, the number one cause of death for people leaving incarceration is overdose. So a criminal justice, sending people to jail does not fix addiction. Because people are incredibly resilient and are able to make good with any situation, yes, some people are able to use any situation to help them be better. so can, yes, learn and grow even while incarcerated. But the reality for most people is that life has been so impacted for the very reasons that Sarah was saying with regard to access to housing, job, the impact that it has on family relationships. All of those things means that this cure that we've relied on for all of these years to address the harms associated with use makes it worse, not better. And so arresting your way is definitely not going to fix the problem. And people have to come to recovery in their own time. That's just the reality. You can't, that's what it was like for me. I did not know somebody can tell me that I need to quit drinking. That was what I had to come to myself. And so people come to recovery in their own space through their own pathway.
Yeah. Right.
I think too, for me and understanding like what needs to happen with reclassification here in Virginia, I think it needs to be coupled, at least in Nathan's humble opinion, coupled with a concerted effort to make sure that there are recovery programs in the jails and in the prisons here in Virginia, well, across the country, but here in Virginia, for the individuals who with a substance use disorder who have what's the word I'm looking for? Other crimes. This is the word. So individuals can get the help and the treatment or the recovery, support in jail that they need so that they're not coming right back out and dying of an overdose that we see over and over and over again as the drugs get worse and worse. So I think it's an important element that as we're thinking about things here in Virginia, what we want to do, and we've seen that, of course, because we all just experienced this pandemic. And I don't know what happened in Rhode Island, but here in Virginia, they just started releasing people without, plans. And so I was involved in those conversations early on, the ACLU and all this coalition that I came to, and I kept coming in. I'm thinking, this is awesome, but I know people are going to die, So we did. It's like trying to stand and hold back a tidal wave. And we've seen that here in Virginia, making sure that we have the pieces in place because we don't want to be incarcerating people with a substance use disorder, but we need to make sure that those who need it get access in jail. And that also brings up another thing too, for me, right? I don't know, again, Rhode Island's like, but I was on pretrial. And when I was on pretrial, I came in every week or every 2 weeks. I had a relationship with a woman, and it's like I came in, I dressed the part, clean cut, and kind of I fooled her. She thought I was doing great. I lost 45 pounds in 3 months in front of this lady, and she had no idea what was going on, and I had no idea what recovery meant for me, and I had no idea that I could stop doing anything. And so for me, the gap there is ensuring that we have CPRSs. I see CPRS at your name, Sarah. Having CPRSs in place to meet people where they're at. Say, hey, you know what? Maybe you got a problem with this. Maybe there's another way. I was in your shoes. That back and forth, that authentic value, that authentic peer relationship. And so I think for us in Virginia that has to be a part of the puzzle. Reclassification is such a big thing, and I see that states like we were talking before the show, Utah, Alaska, I think Oklahoma, big conservative, bastions that have seen that for different reasons have seen that reclassification is important. How do we continue to make the argument that this is the way to go without I don't know. I feel like I'm in such, and we have a blue house, a blue state senate, a blue house of delegates. We got a blue governor here in Virginia, and still we couldn't get reclassification out of the committee. And it's furious to me that we can't get this simple idea, that maybe we need to think of something better. So I'm really grateful to see that you guys have done it. I don't know what else we can do here. That's what we're going to be working on. You're helping me write my op-ed, by the way. Any other thoughts on this? Because I know the big deal. The big deal is I'm calling it safe consumption sites. I know you had a different name, and I don't want to use the wrong terminology, but I know this is historic because it's the first in the nation. So talk about this bill. We briefly talked about it at the beginning of the show, but let's talk about this in an expanded form. Why did we do this? Why is this happening? What does this mean for people who are who are using, and what does it mean for people who there we go. Thank you. Mean for people who are using in those sites when they leave the premises and maybe run into law enforcement. Michelle, you took yourself off mute on that one. You want to answer that?
Well, we actually have a lot of work to do before we can open up the site. There's the health department is gonna has to come up with regulations. Our local governments have to pass. So it's happened at the state level, but there's a lot of work to actually get it going, to get that, to open the doors for a harm reduction center. And part of that work, and Haley can speak to this better than I, but part of that work is unquestionably going to be having conversations with local law enforcement, because I've talked to a lot of people about what they think about, people who are using and who are have a lot of concerns about how are they going to be treated? Are they going to be targeted? And so we have a lot of work to ensure to build confidence with folks, and also to bring law enforcement on board that they will not be harassed.
That's awesome.
Yeah, I have a little bit of a difference of opinion on that, just from having experience working with law enforcement, that and we'll have to meet as a community to find out what everybody collectively feels it will be the best approach here. But we haven't had buy-in from law enforcement or cooperation. As a matter of fact, there was a local harm reduction agency that was doing tabling in our overdose hotspot in the state of Providence. And they were distributing things such as socks, syringes, naloxone, bottled water. And they were finding that as soon as people would leave the table and get out of sight, that cops were pouncing on them, identifying them as people who use drugs. And they would not back down. And we took it to the mayor's office, and it goes all the way up. So I'm personally more of the mind, and I'd love to hear what everybody else has to say out in our home state once we get going, where I think that a more effective tactic might be something along the lines of like a Planned Parenthood thing, where a person is escorted, because once they leave that protected force field, all bets are off. So, we can't predict what this is going to actually look like. Fortunately, unfortunately, we're the first here in Rhode Island. We're just working really hard in between now and the time where this pilot program actually comes to fruition, to make sure that we can do it as seamlessly and safely as possible. And I'm confident that that will be the case.
Yeah. I love what you said earlier about total body autonomy. Am I quoting you correctly, Haley?
Correct. Very correct. Yes.
I love that. I love that idea, because for me, my evolution of my understanding of what harm reduction means, I first got into recovery, and my first introduction was a 12-step abstinence-based program, and that was it. Anything else, and I'm going to die. And it turns out there are other approaches, there are other pathways to recovery that don't necessarily mean abstinence-based. And so, I know what's been working for me, and I'm not eager to change that up right now, but that doesn't mean in the future I could possibly change it up, but I should not, and I won't continue. I won't put my recovery on somebody else. And this is what I've been learning through this whole process. And so I'm really grateful to have you all to talk about this, because this gets to the absolute compassion and meeting the person where they are. And I think that something like this, I'm very eager for us to watch. I'm eager for the country to see what happens. And as a component to whatever legislation, going down the line, where we move towards, in Virginia, we keep talking about moving towards a Portugal model, looking at Oregon and seeing what's working and what's not working there. We've had some people on here talking about some things that may not be working with Oregon, but looking at how we can incorporate the good from that, the good from what y'all are doing, and elsewhere around the country to put together, better ideas here in Virginia and ultimately federally. So awesome work on that. What else needs to be done? And what's the, I understand that communities can say that they don't want the, I don't know what that noise is, I'm sorry. The communities have some say in whether or not they have these safe consumption sites in. Is that what I understand? The bill is 4 pages long? I read the bill.
It's up to each municipality's city or town council. So the communities don't actually get buy-in, although we'd like them to have buy-in, but no, that's not a component of this law.
Okay, and actually, what I meant was municipality. So okay, and I used the wrong word there, but okay. And so, what do we think? What do we think is in terms of what happens if every municipality says no? What happens then?
We keep trying, but there's been initial support from our hub city, and we're pretty confident that that won't be the case, and that there might be several of these facilities that go up at once.
Awesome. Michelle, I know all three of you are in long-term recovery from what you shared at the beginning of the show. What brings you to this work? What brings you into what you're doing, and why do you continue to do this? And how do you nurture your own recovery?
Oh, that's a great question. So for nurturing my own recovery, it definitely is my relationships and the spending time, my relationships with my friends and family and coworkers and colleagues. Doing this work has been really important to giving back. I mean, that's part of what recovery is giving back. And I guess I really became involved in this work. I was doing HIV prevention work for, I started when I moved to Rhode Island 25 years ago. I started out in HIV prevention work. And it was actually working with folks while they were incarcerated. And it was when my eyes opened to how our criminal justice system works, the incredible discrepancies and biases in our criminal justice system, and honestly watching people who were suffering with addiction dying when they were walking out the door. And that was to me was like, this, we can do better than this.
That's awesome. Yeah, and thank you for continuing to do that work. Sarah, really the same question. What gets you involved with this, and how do you nurture your own recovery?
Yeah, so it's funny because before I started doing peer work in around 2018, end of 2017, and I was really hesitant to join this workforce. I was really fearful of it. I was fearful of it being traumatic or compromising to my own recovery. I haven't found any of those things to be true while working in the field since then. If anything, working in this field keeps things very green for me. I'm very fortunate for my recovery. So like Michelle said, what keeps my recovery robust and strong is the relationships I have with other members in the community who are also in recovery, whatever that means to them, whatever definition they choose to apply to their recovery. I have a sense of purpose now, not just my job, but outside of my job as well. Like I think that my job is working in this field is beneficial to my recovery, of being of service and realizing how fortunate I am to be in sustained recovery. But it's not what drives my recovery. If my job drove my recovery, I don't think I'd be doing too well. So I try to build my personal recovery outside of work as strongly as possible so I can come to work and do my job as effectively as possible, to avoid burnout and to be always compassionate when approaching somebody. I know when to take a step back and like, okay, I think I'm a little bit burnt out, maybe some compassion fatigue. I need to take a break and focus on my own self-care, my own recovery. And also, you were mentioning, Nathan, the kind of marriage between harm reduction and recovery. So I also came up in a 12-step program. That is how I found my recovery, which I'm very fortunate for. I'm very grateful too. But I understand the importance of harm reduction in that holistic approach when addressing, especially the overdose crisis, but every substance use or drug use disorder, or drug use as a whole. Realizing that my personal recovery isn't what the next person's is going to look like, and never placing that on the individuals that I serve. Sorry if you hear the motorcycle in the background.
I
But
was
having
getting
a
excited there for a minute.
but having a humanistic approach in every interaction that I have is I acknowledge the fact that some people don't want recovery. They may never want recovery, and that's okay. Like, I honor their experience and where they're at and what they desire from life. Like, maybe someone just wants to use substances, and they're okay to do that. So knowing how to honor each individual experience and understanding that everyone is an expert in their own life. I probably got a little on a tangent there or off the topic, but yeah.
That I excel with tangents. So same question, Haley. You know what? Why do you do this work? And really, how do you maintain and nurture your own recovery?
Sure. So, I would say, why do I do this work? I kind of fell into legislative policy. It happened all of a sudden. And I just have a lot of love for policy. And we're kind of spoiled out here in Rhode Island. So we've got Brown University right up the street. We've got a really strong recovery community. So it just kind of fit. And it made sense to try to pull all these pieces together. And that's doing what I love. So I absolutely love writing policy. I love lobbying. I got weary, to be honest with you, of doing clinical work in direct care where I'd have people sit in front of me with the same stories, felony possession charge. And it became like, as important as I think the direct care work is, I looked at this and then I looked at the bigger numbers and said, all right, this is happening to all of these people at once. And how can we try to solve this with one fell swoop? So less people are dealing with this. And that for me was a big part of the appeal. To sustain my own recovery, close with my family. I love my parents. I have really good friends. I also do a lot of direct action, which really kind of feeds my soul. And do a lot of other criminal justice reform, and it makes me confident to see everybody working on this, that the world's just going to be in a better place, and that people are going to be a lot better off and happier and safer, and that just drives me.
That's beautiful. I do want to get to Robert's question over here. He had two, but no, the one above Justin. Big thing down here in Virginia and probably across the country, but Good Samaritan laws, better Good Samaritan laws. Here in Virginia, we had a Good Samaritan law. I guess you could just call it a Samaritan law, really. And it became a decent Samaritan law, and then it had to become an even better one because something happened. So I know Robert knows more about this than I do. Robert's question is, any talk about making a more comprehensive Good Samaritan law like what Vermont has done, so that virtually no one has to worry about legal issues before calling 911. If an overdose was treated like a heart attack, a lot of lives would be saved. Absolutely.
Yeah.
I don't know what the laws are in Rhode Island about Good Samaritan, so
I'll just speak briefly on this because I know Michelle has had a huge part in the Good Samaritan law, and we are in talks of kind of editing it and bringing it up to date and making it more encompassing and more protecting. I think that's actually probably, at least for me, next on the list of hoping of what we could accomplish next. So we do have a Good Samaritan law, and it does protect individuals who call 911 who in good faith are seeking help in the event of an opioid overdose, right? Or an overdose, and that they are protected, that they won't be searched and won't face punitive measures for calling 911. That doesn't stretch to manufacturing or distributing. So it's pretty there's a vagueness to it that leads a lot of loopholes. And also, in my experience as an outreach worker, a lot of the individuals that I serve have called 911 in the event of an overdose, doing the right thing, right? Trying to save somebody's life, doing what we tell them to do when there's an overdose, call 911, administer naloxone, and have faced punitive measures as a result, even though they were well within their right to call 911, and these punitive measures should have never happened. So even with the law being in writing, it's not always upheld by law enforcement. And will this get dismissed in court? Probably. But now this person has to go through the headache of going to court, paying court fines, dealing with the repercussions of something that shouldn't have had a repercussion in the first place. So I think it does need some revamping, and some really concrete guidelines are necessary because there's too much discretion with law enforcement at the end of the day for them to decide what they want to do with a law, whether they want to practice it or not. So that's just my experience as an outreach worker, especially in the past year. There's been many individuals who had faced repercussions when they shouldn't have when calling 911. And I think that, of course, is not solely the responsibility for why we have an increase in overdoses, but it's not helping those numbers.
Sure.
People's lives that could have been saved if 911 was dispatched and they actually upheld the law like they're supposed to. I think we could have had lives saved. At the end of the day, I don't think law enforcement belongs on the scene at the event of an overdose because it's a medical emergency. Like Robert had mentioned, if it was a heart attack, it would be treated like a heart attack, a medical emergency. And that's all an overdose is. And that should only be treated as such. There's no need to search someone's name or search the premises. You wouldn't do that if someone was having a seizure or a heart attack. So it just rooted in the war against drugs and stigma. So I can go on a long time because it personally affects the people I serve on a regular basis, and I'm sick of people dying. But I'll end there. Michelle, if you want to say anything.
Well, I want to ask a follow-up question to either Michelle or Sarah or Haley. Does the law in Rhode Island protect the individual experiencing the overdose? Because the law in Virginia did not do that. So when they changed the law to give greater protection to the person making the phone call and the person experiencing the overdose, this is what happened. Somebody who wasn't the caller or the person experiencing the overdose, however, this person, a third person, was actually administering naloxone to the person. So guess what happened when the police came up on the scene? Person making the phone call, fine. Person experiencing the overdose, fine. Person administering naloxone, arrested. So we went back and I didn't have much say in this until after it went into committee. But when it got to committee, we fought for this, and we went and we actually got that to change. So we did make it I think we increased and made it better, but it just seems to me like, to Haley's point, the police around here are always going to find a way to get in there, and it's like, hold on. And to that end, because what I'm hearing is the police are getting exhausted with the multiple overdoses and responding multiple times to the scene, which only tells me this: the emergency departments continue to treat and street. It's like we're not giving people access to anything else. Anyway, that's my little soapbox there. There were a couple comments up there. I know, Justin, there was a comment from Debbie. And we can continue the Samaritan Law, but this, thank you, ladies, for such strong advocacy work. It's a beautiful thing to see 3 strong and passionate women in recovery giving back to their communities and making change happen. Debbie is a board member here at the McShin Foundation. She's a longtime watcher. She's hosted a couple times too with families, and thank you for participating or listening today and commenting, Debbie. It is really wonderful to have all of you here and talking about what's been going on in Rhode Island. It's been very exciting to watch. Continue to be impressed with your strong, passionate advocacy. Before I'm going to land the plane, as Justin over there is doing the hand signal, any thoughts on what next or how we can improve our advocacy in Rhode Island, but also advocacy in general? How can we improve? Who would like to start? Anybody want to say anything about that? Haley?
Please reach out if you need help with defelonization efforts in Virginia. I'd like to have a conversation about drug dealers starting next year and expand our other stuff and just, see what the outcome of all of this policy is going to be. And I'm really excited to see what that looks like. But, part of this and the reason we got to where we're at is not only having support from people locally in various different areas of expertise, but also looking at what they're doing in other states. So if we can be of any service out here on our little island of Rhode Island to help you all along in your efforts as well, please feel free to reach out. We're happy to support.
Awesome. Thank you, Haley. Any thoughts, Michelle or Sarah?
Yeah, I just want to chime in real quickly. So as a person in recovery, I didn't know that my voice was always valuable or that I had any stake in anything, especially involving legislation. It's not necessarily my wheelhouse. I think that I could serve as a great advocate given my experience and my the field that I work in. But Haley was someone that really encouraged me to come along with her to do lobbying on bills. I'm like, I don't know, people in suits, we don't mix. But actually, Haley always reminded me, like, no, you're an expert. You know more than them on this topic. So really encouraged me to honor the fact that I do know a lot about this topic, and my lived experience makes my voice very valid. So I just want to reiterate what Haley has taught me in that regard, and encourage anyone who's in recovery or is an ally to people in recovery that you could also just lobby for a bill. If there's someone there who can write it, like, I'm not in a position to necessarily write bills, not at this time, but you can go and advocate for it, speak with legislators, call your local reps, and kind of just be a thorn in their side. Continue to always show up, share your story, share your experience. I think that having personal testimonial really helps open a lot of legislators' eyes to the reality of it, because either it's going to pull out their heartstrings because they can identify, because this, like Haley was saying, this affects all of us to some degree, or if it doesn't, maybe they don't understand. So maybe they need to hear it from someone that it directly affects, or that is seeing it on a ground level. So I think that anyone could be an advocate. So I think just get out there and do it. And I think your voice is really important and very valuable to the process.
Absolutely. And my first little foray in recovery advocacy, somebody reached out and said, hey, we need a voice to talk about felony murder charges for individuals gifting drugs back and forth. And it's a bill that that's a bill that passed with a I guess it was in the last General Assembly. It was a red General Assembly, and it passed, but it got vetoed by the governor. And that's where we came in. That's when it was actually the ACLU of Virginia who reached out to us and said, hey, does anybody there want to speak? And I and a couple of my other, I was a McShin participant at the time. A couple of the participants came and sat with the governor's policymakers, policy decision directors, or whatever their lofty little titles are, and said, this is why this is affecting, this is why this can't happen. And I quoted the New York Times. I was all so smart. I came in with a New York Times article, but the reality is they just sat and they listened. They listened to us, and it turned out, we got a favorable outcome. But that was, what I realized is that these are people too. These are people who do want to see the better things for our Commonwealth here. So, Michelle, did you want to say anything final?
Follow up with what you just said, Nathan and Sarah and Haley, that this is the work of many different communities coming together. Mm-hmm. So the fact that ACLU reached out to you, it's like, I think that's been one of the things that's been really successful here in Rhode Island, is there's a lot of different communities that have come together around this. Folks who are involved in criminal justice work, folks who are involved in harm recovery, treatment, harm reduction and recovery, and researchers and providers, it's everybody has a stake in it, and really being sure to try to bring into the fold as many different communities as possible. Excellent.
Something that we say here in Virginia, and I guess recovery means what it means to the individual. So I'm going to say this broadly and in no way putting my recovery on somebody else. But what we say in Virginia is when we invest in recovery, we build stronger families, we create safer communities, and we produce healthier citizens. So on that note, I do want to say thank you to all of our fantastic guests. I'm really excited to have had you here, guys, have you folks here today. Sarah Edwards, Michelle McKenzie, and of course, Haley McKee. I do want to say one thing. We are in July, so that means we are celebrating 17 years this year. And what that means is that the McShin Foundation has had their doors open for 365 times 17 plus a few leap years in there. And that means even during the pandemic, when we adapted and accommodated, even while our community services boards, which is our Commonwealth's health districts, had to close the doors because of COVID, even while treatment centers had to close down, even while emergency departments were turning people away, even while the jails were releasing people early, McShin kept the doors open to provide same-day access to recovery support services. And thank you. I appreciate the applause. And what that means, though, is that our little community-based non-governmental organization here is at its limits. We need some funding. And I know we've had that thing going, scrolling through and asking for funding here. And I think all of us can probably agree it would be great if we could just work our way out of a job here and not have to go bang the drum for money and hold the hat out. But the reality is we got to do that. And so if you got a second, you got a few dollars, you want to put it in the kitty, help the next person in recovery, that would be really appreciated. I do thank you for that. Thank you to all of our listeners, all of our viewers. Thank you to Justin, my faithful producer over here. Tomorrow, we've got Honesty Liller with the Women in Recovery with Joyce and Dixie. They'll be talking about 17 years. We'll be talking about McShin and what we've done, where we've been, where we are, and where we're going. And then on Thursday, I just pulled out the sheet. Thursday, Justin, who do we have on Thursday? You don't have it either? I've got it right here. Thursday. Oh, gosh, how did I forget about this? So, ladies, you might enjoy this too. Mariel Huffnagel, she is an advocate in New Jersey, and she has an incredible story that I haven't heard her tell yet, and I'm eager to hear her tell that story. I've only read about it. So she brings an incredible experience, strength, and hope to the table, and she'll be sharing with us on Thursday and talking about what she does in the recovery advocacy sphere right now. I'm very honored and honored to serve on a committee with her. And so I asked her to come and share with us. So thanks again. Have a great day. And congratulations, Rhode Island, on that.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Nice meeting you.
Nice. Thank you so much.
Here at McShin, we believe in the McShin way, which is authentic recovery support service providers, people with lived experience, bringing that experience to those who need that lived experience in recovery.
Here at McShin, we believe in many things to support our mission. We believe in women empowerment.
What I love most about what we believe here at McShin is we believe in the authenticity of the peer-to-peer approach.
Here at the McShin Foundation, we believe in giving people opportunity.
Here at McShin, we believe in the inherent worth and dignity of every person.
At the McShin Foundation, we believe in helping people reach their full potential.
Here at the McShin Foundation, we believe in multiple pathways to recovery.
Here at McShin, we believe in placing principles before personalities to help spread hope.
Here at McShin, we believe that recovery is possible and that any person seeking recovery can become a more acceptable, responsible, and productive member of society.
Here at the McShin Foundation, we believe in self-discovery.
Here at McShin, we believe in saving lives and offering second chances.
Here at McShin, we believe you can do this.
Here at McShin Foundation, we believe that we can only keep what we have by giving away, which is why we continue to help others like us seek and find recovery.
Any place, we'll get